All right, everyone, it is noon. We're going to get started with this call. And this is part 4 of the 6-part series on the ACM assessment program. And today's topic is on standing rotation assessment. And again, this is one of 6 assessments that we use in the ACM. We're going to get into a lot more detail as to why I choose this assessment, the order we put it in, and what value we're getting out of this assessment, and how it can help direct you in a corrective approach. So when we talk about the standing rotation assessment, we're looking at internal and external rotation components of the hip. There's a lot of other aspects to this that we'll talk about, but that's the biggest kind of takeaway from this, and we'll get into more detail with that. But we're essentially looking at the transverse plane of the body's movement in a loaded position, and that's the rotational pattern. Unilateral assessment, so we're looking at both sides in the transverse plane, hip internal and external rotations. We're looking at torso rotation as well. We'll talk about the influence of torso rotation, thoracic and lumbar, as well as the center of gravity distribution, which is an important part to understand about the standing rotation assessment. So if you are familiar with this software, you haven't gone on and start using the software, because the ACM assessment program is very easy to implement once you understand its components. The software already takes care of most of the problems. So on the software, when you're at the standing rotation assessment part of the assessment, there are a handful of different variables, but we're looking at unilateral movement here. So we're going to have a right and left side to assess, and you'll have an option to choose yes or no. Are they able to rotate their pelvis to 45 degrees? That's all we're really looking at here. And they either can or they can't. And so you have to really get a good keen sense or an eye for what 45 degrees is in pelvic rotation, so you can see the difference right to left. And if you do enough of them, you'll start noticing it right away. One side will be locked up, one side won't be. So in this situation, the person can rotate to the left with their pelvis 45 degrees, and then to the right 45 degrees, and that results in a functional pattern, and you'll get the little F on the side. Somebody that has a difference, or I'm sorry, not a difference, but they're not able to rotate both directions, right and left, to 45 degrees, that results in a dysfunctional pattern, meaning it's even, but it's dysfunctional. If someone's able to not rotate to 45 degrees on one side, like the left side here is a no. Oh, shoot, I have the wrong slide in. Anyway, this slide should be, yeah, take this one out, this for sitting. Standing rotation, again, right or left side. If one's functional and one's not functional, they're able to rotate one way, which you're going to see very often. One person can rotate 45 degrees or more in one direction, but they're very limited on the other side. Whether it's right or left, it's going to result in an ADF, asymmetrical dysfunction. And so it'll show up here on the results side of the assessment as ADF. And that's all you're really assessing in this pattern for the software. The algorithm set up to understand what those 3 patterns are: functional, dysfunctional, and asymmetrical dysfunction. Now, there's a reason why we are doing the standing rotation in the order that we have in the assessment protocol number 4, and we're going to talk a lot more about that, how the first 3 assessments built into the standing rotation, what you should almost be able to predict from the 3 first assessments, and what you might find in the standing rotation. And again, it's a assessment and a validation of those first 3. So in the standing rotation pattern, and sometimes I'll have people hold a stick across their shoulders just to give you a better perspective of what a perpendicular angle is and how it relates to the movement of their pelvis and their torso. Or I just have them cross their arms and rotate. You can get the same effect. The stick just gives you a better understanding or visual appreciation for where they are, and it helps the client see that as well. But it's not necessary. Again, standing rotation, what we're really looking at is the internal and external rotation components of the hip, the pelvis rotation side to side. The toe touching pattern, we talked about hip flexion and how internal rotation was synonymous with that. And the backward bend pattern talking about extension of the hip and how external rotation was synonymous with that. So from the toe touching pattern and the backward bend pattern, we're already starting to get a good prediction of what we're going to find in the standing rotation. And so someone who's very restricted in toe touching may also mean they're very restricted in internal rotation. You're going to see that come out in the standing rotation pattern. If you, or vice versa, if you see someone with limitations in extension, especially hip extension, you might find that in their standing rotation pattern because of the limitation in their internal external rotation. And we're going to talk about how to differentiate internal external rotation. We're going to get into a lot of that here in detail. But I'll tell you one thing that this assessment does is it starts to give us a clear answer as to the asymmetries we talked about in the toe touching or the backward bend pattern. Backward bend pattern is looking at bilateral symmetry of the body moving into flexion, but you will find people that have asymmetries in that pattern from this frontal view, and that asymmetry that you're seeing appear in a muscular girth or a muscle atrophy or a size difference in the spine or a pelvic elevation in the pelvis in someone's touching toes will start to show that asymmetry in the rotation. And so if you found it in a toe touch, you found it in a backward bend, then you can pretty much, you can start to predict that you're probably going to find it in the standing rotation because we're isolating right to left. And that's why we go into a single leg toe touch, single leg backward bend assessment. If you find a really big asymmetry, you can confirm whether it's toe touching or backward bend. And we said the toe touch is synonymous with internal rotation. The backward bend is synonymous with external rotation. So if you're finding an asymmetry in their bilateral movements of toe touch, their bilateral movement of backward bend, break it out into an asymmetrical movement here with the toe touch or backward bend, and it'll give you a better indication. So for instance, if someone's bending over to touch their toes, the right leg down, we're assessing that the left hip flexion and essentially internal rotation. In the standing rotation pattern, if you see a limitation in this position, you're going to also find it in that standing rotation where their internal hip rotation is probably limiting that movement. So it helps give you a clear understanding of whether it's internal rotation or external rotation, which we're going to talk about here in a second. So hopefully that makes sense. Again, the standing rotation pattern is the fourth in the series because we're building on top of the ankle mobility assessment, which we would determine functional, dysfunctional, or asymmetrical. If you're finding an asymmetrical dysfunction in the ankle mobility, you can predict that as we get closer to looking at the asymmetrical assessments like the standing rotation, the sitting rotation, and single leg stance, you're going to start finding those. And so just keep that in mind. If you find a functional ankle mobility and a functional toe touch and a functional backward bend, then you're not really going to predict. You still want to check, but you're not assuming, or you're not really looking into finding a big potential problem with the standing rotation. And again, if you do, then that gives you some more insights as to what could be going on. But very rarely will we find a functional ankle mobility, a functional toe touching, a functional backward bend, and then find some kind of asymmetrical or dysfunction in the standing rotation. But if you do find dysfunction or asymmetrical dysfunction in ankle mobility, toe touch, and backward bend, then you're going to probably start seeing it in the standing rotation pattern. Remember, toe touching, we're not really assessing asymmetries, but you can observe that. Same with the backward bend. It's a little more challenging to observe an asymmetry in the backward bend unless you're looking at the shoulder flexion and the shoulder flexion we talked about. So again, the standing rotation pattern builds on the last three assessments, and it's giving you a better predictor and a way to validate what you're seeing in the other patterns. Hopefully that makes sense to you guys. So when it comes to the standing rotation, the instructions are to put your feet together, always together, because if the feet are apart, we're not going to have a way to replicate that pattern every time. And also it's the hardest position to move from, so we're looking at giving someone the most challenging position and seeing how well their body moves. Have them rotate to the right in a slow pattern, a slow controlled movement, have them rotate to the left and hold. I usually have them hold it for a second or two, and I'll have them return back both sides so I can get 2 or 3 assessments, 2 or 3 tries to see how far they actually move. A big part of what I'm looking at is to see how much foot movement there is, how much knee flexion there is on the opposite side, anything they're doing to cheat for that internal external rotation. In the standing rotation pattern, we can assess or assume that we're getting mostly, we're basically looking at the rotation of the acetabular head, the head of the femur in the socket. Although we're going to get a little bit of rotation out of the ankle, very little. The ankle doesn't rotate, it everts. But we're going to get a little component there in the knee. It's a very minimal amount of rotation in the knee, but there is some. It's negligible compared to what we're really trying to achieve or look for in the hip pelvic complex of movement. I'm not necessarily looking at how much torso rotation they get, and I'll share with you why that is later, but I do observe the torso rotation, and it's another predictor as to where they're trying to gain more rotation from or more movement from if they're not getting it from the pelvis, and we'll talk about that. So the components of the standing rotation pattern, thoracic rotation, we're looking at how far the thoracic back rotates. It's a big rotational component. There's some lumbar rotation, there's minimal, but there is. We're looking at obviously pelvic internal external rotation, and also center of gravity orientation. And I'll show you some variations in that in a second. But I'm looking at these four things primarily when I'm having someone stand and rotate. And again, paying attention to the cues of their ankles and their knees if they're doing this to cheat. The biggest thing is just tell people to cement their feet in the ground and don't let them move. Lock your knees and rotate. I don't cue them too hardly on how to rotate, just turn. They'll figure it out, and when they do figure it out, you start to see variations in how they find a way to rotate their body in these patterns here. Again, one thing to step back with and understand is our body doesn't work in one plane. It's a triplanar movements, flexion, sagittal, coronal, and frontal planes. But the transverse plane is primarily what the body functions through. And we really need to understand that transverse plane, that rotational plane, is very important to maintain or to improve restrictions from. So when we go into the pattern, again, we're looking at essentially looking down from the top. We're looking to see that the pelvis rotates to 45 degrees. And you can assume that the pelvis, when we're standing straight ahead, is at a perpendicular angle to where your nose is pointing, and we're just looking to see how far everything turns. We're looking at the pelvis and a combination of the torso to 90 degrees, but the torso, we can cheat. So I took away from this assessment the idea of what the thoracic back is doing. I've only focused on the pelvic rotation component, because we're going to find that thoracic rotation limitation, if there is one, in the next assessment, sitting rotation. So that's essentially what we're looking for, is that pelvis rotates to 45 degrees, and you'll have to just kind of play with those numbers. It's pretty obvious when you see someone that can rotate past 45 degrees or someone who's really stuck 20 or 30 degrees. You can tell they just aren't able to move at that pelvic acetabulum. This is just another way of looking at it. Standing straight ahead, the pelvis and hip sockets are square, perpendicular to the way you're facing. When you turn to the right, the left femur is externally rotating. I hope you can understand that. And the right femur is internally rotating on that center axis as you spin or rotate. The same and opposite on the left side. If you're rotating the pelvis to the left, the inside leg, the right leg, is externally rotating, and the left leg is internally rotating. And so the question is, how do you know which is which? How do you know if someone's restricted? Is it internal rotation or external rotation that's causing it? Because you're looking at two different movement patterns in the same movement here. And that's why the toe touch and backward bend are essential to understand what you're seeing there first before you get to this. And a lot of times I'll always ask someone, where do you feel restricted? And most people will say they feel it in their back. And that's because that's where they're trying to gain more movement from. And the lumbar spine is the facet joints are orientated vertically, so they're not really suited to rotation, very minimal rotation. We'll look at that in a second. But if they're feeling in their back, it just shows us that they're getting too much rotation compensation for a lack of somewhere in the hip. When they haven't focused on where that tightness is, they'll probably tell you it's in one of the hips versus the other. And it will make more sense if it's rotating to the right and they say that their left hip feels tight, then that just tells us that they're having difficulty in achieving external rotation on that hip socket. Or if they're rotating to the right, and their right hip feels tight, that's an internal rotation problem. And it just kind of cues you into what one could be causing which. Going the opposite direction, they may have perfect range of motion because they're now going in the direction their body likes to go. So just be aware of how that plays out in the assessment, right versus left, and internal and external versus each direction. Make sense? I mentioned to you that not only am I looking at the rotation of the spine, and primarily I'm looking at the pelvic rotation, but I will pay attention to the spinal rotation and where they try to compensate or get spinal rotation from, just as a observation. But the center of gravity, the distribution of center of gravity in the standing rotation pattern, let me just do this so it looks nicer. Too much about aesthetics here. Standing rotation pattern, the center of gravity distribution, and starting out, I'm looking at that center line of their body's posture, that line of gravity. And as they rotate, are they rotating on that line of gravity, or are they offsetting? And you will see people have a great sense of stability through this pattern, and they're able to maintain that center of gravity through the distribution line of gravity. This girl that I use as my model, it was really interesting to watch her do this because you can tell her body offsets. She rotates the pelvis, but the torso tilts forward. And that's just looking for rotation where she doesn't get it. And she actually had I believe it was her left hip, or it may have been I don't remember now, but she had I think she was stuck on her left hip. She couldn't rotate to the left, and it was due to her left hip tightness. But she would offset to the side, and it's subtle. Some people will do exaggerated movement, but you'll see that, and that's something to pay attention to, and it keys you into. You've really got to break out what that hip is doing because it's not allowing them to rotate. And again, that's what the single leg toe touch, single leg backward bend really kind of gives us some insights to. If you find someone that has perfect toe touching pattern, but they're really restricted in extension, then you can start guessing that it's an external rotation problem. These two models, if you remember the pictures, you may not, but this gentleman's backward bend was tremendous. I've never seen someone with so much hip extension and thoracic spine rotation extension. His toe touching pattern was horrendous. Couldn't touch his toes. He actually could touch his toes, but his back was completely rounded. He's got no internal rotation. So he's got an acceptable range here, but he is definitely restricted in internal rotation. So if we found some restriction here, we're going to find it, and we're going to assume that it's going to be an internal rotation problem. Moving on, this just goes into the spinal alignments that we're talking about. And why I don't really pay attention to, I don't use that as part of the assessment here because there's too many variables. It's multi-segmental movement. But we're looking at, I'm just taking notes as to, do I see or do I replicate discomfort they have in rotation in their low back or their upper back? And it will help key you into helping them understand that that is a result of your inability to rotate from your pelvis. And it's just a way to help them, educate them as well as you. But here, yeah, I'll actually change this slide. I have the same diagram here, but understand we're looking at vertebrae, the components of movement relative to the level of the vertebrae, cervical, thoracic, or lumbar, are based on how much movement and flexion in the cervical spine, how much extension in the cervical spine, how much lateral flexion tilting to the side, and how much rotation. And as you can see, the cervical spine is really geared for rotation. We know this. The thoracic spine is about half of that movement of rotation, but it's pretty balanced. 50 degrees of flexion, 45 degrees of extension, 40 degrees of lateral flexion, 30 degrees of rotation. It's a balanced movement system, the thoracic area. Lumbar area, obviously flexion is what our lumbar spine likes to do. Extension is very limited, and it's, again, why the backward bend pattern, we're really looking at thoracic extension, that position. It's not comparably to the ability of the lumbar spine to go into flexion. It's about a third of that in extension. Lateral flexion is about the same. The vertebrae are not aligned to allow for lateral flexion, and even less so in lumbar rotation. So when we're looking at someone standing and rotating in the standing rotation pattern, we're not really, if we're seeing excessive rotation in the spinal position past 90 degrees or tilting or a pain, we can assume that they've lacked some rotation either in their thoracic back or their hips, because that lumbar spine is not supposed to rotate much. So anyway, it just keys you into understanding spinal movement and where these assessments fall in place. I threw the same slide in here just to give you an example and underline the rotation component, because if we're looking at, and you can see that cervical spine is what's primarily the rotating component of the spine. The thoracic is about half of that, and lumbar spine is minimal. And again, it's based on the orientation of the facet joints that line up on top of each other. And that's all I'm going to share with that. So when it comes to the actual hip movement, I've shared this before in the other patterns, but the hip socket is like a finger cuff, and the hip socket, the ligaments that surround the hip are really designed to support the loaded structure standing with tension to minimize muscle effort to stand in one place. As the knee, you can imagine both of these images, right and left, or anterior and posterior, sorry. When the leg is in extension, the hip is in extension, the bands of ligament wrap around the hip socket and tighten it up, just like a Chinese finger cuff. When you bend the knee up into flexion, or I'm sorry, the hip up into flexion, you bring your knee up to your chest, that tight ligament wrapping unwinds itself and allows for free movement. We're going to talk about assessing this in a second. So just remember that when we see limitations in movement of the hip socket, it could be part of it due to the tightness of the ligament capsule itself, and that's why joint mobilization is really important. But also, someone who's hypermobile may not have the control to stabilize that hip movement. So just paying attention to those kind of things. Here's what I did. I put together a list of the muscles that we want to really be thinking about. And again, I'm not a fan of isolating parts, but I will tell you that limitations in hip rotation, if we're finding a pattern right or left that's restricted, and we can kind of infer or come from the other assessments that we understand that it might be internal rotation that's restricted or external rotation that's restricted, then we have some ideas as to what musculature is having a part of this. Could be a hip contracture in the capsule, the ligament, but you're going to have a lot of influence from these muscles. And these are the muscles that are responsible for internal external rotation of the femoral head. Again, hip joint restrictions could be anterior, inferior, inferior joint capsules. I should actually put posterior here. Posterior joint capsule. The hip musculature, we'll talk about that. And then obviously the center of gravity distribution, the lack of internal external rotation. The center of gravity distribution could actually be straightforward, a core stability problem, but we don't want to assume that until we've really identified this. So when we look at the table of muscles responsible for external rotation, so if someone were to turn to the right and they're tight and they feel on their left hip, that means that they feel on their right hip as they're turning to the right, that right hip is going into internal rotation. If it's tight, it could be something, the musculature is probably responsible for supporting that joint and limiting its ability to move, and it could actually be what causes the head of the femur to get jammed into the socket tighter, which is what they talk about with acetabular impingement, like joint impingement of the hip socket. It's usually in superior superior acetabulum impingement, where the head of the femur slams up into the acetabulum and the labrum of the socket. So you can start thinking that glute max may be tight. Glute max is a strong external rotator. It's a hip extensor as well. I would almost say that your deep six, piriformis gemelli, obturator gemelli inferior, obturator externus, and quadratus femoris. Your deep six external rotators are called that because they're your external rotators. They tend to be very tight. Someone with piriformis syndrome will probably have a very tight rotational pattern here because of the tightness of these external rotators. So if you're seeing a restriction in rotation to the right, that right femur is probably tight in external rotation, or the external rotators are very strong, tight, and they're not restricting this movement. Something to think about. Also, your iliacus and so as muscles. Your hip flexors are external rotators as well as hip flexors. So when you bring your knee up, it'll actually pull the femur outward or externally rotate it. So those can be tight as well as sartorius and biceps femoris. Sartorius is the muscle comes off the ASIS and down into the pes anterior group. Those muscles can be, that muscle that wraps over top of the leg, very superficial muscle, can be extremely tight. It's a hip flexor, it's an external rotator, and actually a knee flexor and tibial internal rotator. It's a really cool muscle. Two joint muscle, has a lot of action, but that can be tight, as well as biceps femoris. Biceps femoris actually helps pull the femur out. It's one of the more dominant muscles of the hamstring group. So if it becomes over dominant for a lack of strength of the glute max or something, the biceps femoris can be very, the bicep femoris muscle, the hamstring muscle, can be a dominant restrictor in that internal rotation, or will really help perpetuate external rotation for a lack of glute stabilization, and etc. So someone who stands with their foot turned out quite a bit and it's a tibial torsion thing, you'll know that biceps femoris is probably playing a role in that. And then going into the femoral internal rotators, just assume that your adductors are probably very tight. Your adductors are hip adductors, they bring the legs together, but they're strong internal rotators. Your glute medius minimus, TFL, all those lateral hip muscles, your abductors, the primary abductors, but they're internal rotators as well. And if your hip is in flexion, and you pass the line of the plane that the piriformis muscle works on, it can actually become an internal rotator of the femur, not an external rotator. So it's just some stuff I have in another chart, but understanding where the muscles originate and insert, and as the hip moves through a range, piriformis can actually pull the femur's internal versus being a strong external rotator that we see. So in hip flexion, you may get some piriformis involvement. So if someone already has tight glutes, or tight external rotators, someone already has piriformis syndrome or sciatica, you may want to avoid hip flexion exercises that are promoting internal rotation, because you're going to be strengthening that piriformis muscle as well. Something to think about. So anyway, hopefully this gives you a guide to go by to start differentiating internal external rotation and the musculature that's involved, and what you would expect to find with a group of strong, tight external rotators versus internal rotators in just postural assessment as well. It looks like I duplicated this slide. Take that out. Again, this is just an overview of the movements of the pelvis and hip. I think I've showed you that a lot. The internal external rotation, again, when we go into toe touching, we're synonymously saying it's an internal rotator. When we go into extension, we're saying that it's synonymous with external rotation. So there are 3 different ways to assess. In fact, I have a study I'm going to send you about this. Internal and external rotation. The majority of studies test internal and external rotation in an unloaded position, and they'll either lay you supine, like this person on the right, and they'll go in internal and external rotation. They can actually bring the foot up in the air in flexion, the hip in the flexion, and look at it. This is prone, so now your hip's in extension. So one is looking at hip flexion rotation and hip extension. So we know about that hip socket and the ligament structure that wraps and holds it tight. By going into hip flexion and then hip extension, we know that we're actually looking at how much restriction that hip socket is causing. And the study I'm going to share with you tested these 3 variations of the assessment unloaded, and they found that there was just as much validity in each one of them. So it doesn't really matter if you're in hip flexion or hip extension, you're going to get the same values for what the actual rotational components are. The problem with that is we don't function in that position. We function in a loaded position, which is why the ACM, we want to do standing rotation pattern. And there's only one study that I found that took that into account, and it happened to be with golfers and assessing their loaded standing rotation patterns, internal external range of motion, which will be an interesting study for you to look at. But so there are ways to do it unloaded, and if you really are concerned, you really want to understand it, then I would have someone lay on their stomach and just see how far they can go, or have them lay on their back and just have them externally rotate and internally rotate, and they'll give you a better indication of the asymmetry if there's one there. But it's just it's just another screen that you can perform to do that. So Hold on 1 second. So let's take a look at the musculature, and I really want you to hone in on the influence the entire body has on movement. And I will constantly be emphasizing this, especially when we talk about the corrective exercises, because our anterior fascial lines, kind of the connections and the contribution that muscles have in a combination is really important to understand. So even though we're looking at internal exrotation of the femur, we talk about specifically your adductors, your contralateral obliques and pecs have a big influence on the anterior chain, especially if you think about rotating and someone's offsetting. That could indicate tightness in that anterior fascial line, or the posterior line we'll look at. But don't just assume it's the musculature of the pelvis. The torso has a big influence on that, as well as the abdominals, mostly the obliques, in this connection pattern, the anterior fascial lines. The pecs, the obliques, abdominals, and adductors, the contralateral adductors, have a big influence in the ability to rotate. And if you're finding asymmetries, you're probably going to find asymmetries in that musculature as well. And you'll most likely see some sort of a offset or tilt or rotation in the torso of the person. And it'll give you some indication as to which fascial line that you can be working on and the connection those muscles have. Your adductor muscles actually attach to the fascia of the abdominals, which attach to the fascia of the obliques and the pec. It's really a cool thing that when you see it, the fascial lines and how it's all connected. So it's really interesting when you see contraction of these muscles from one group, the other muscles get involved, and it's kind of neat to watch. The anterior chain, we were talking specifically about the lower extremity, but again, the psoas here on the lumbar spine and iliacus of the pelvis pass through that mid-range of the body, connecting the torso or the spine to the pelvis. And then again, you see the adductor attachments here on the pelvis, and then some of the TFL on the side. I'm just giving you some insights to the musculature of the lower body. And then obviously the adductors have a big influence on the rotational component. Even though they're strong hip flexors and adductors, they're also internal rotators. Except, and again, I always isolate adductor magnus. Adductor magnus in a posterior portion of that muscle, this being the posterior portion, a big part of that muscle, in fact, magnus being magnus, it's a large muscle, can contribute to extension and external rotation slightly, but it's really a strong internal rotator. So understand that as you're going through this, these muscles can be very tight, especially someone who has a posterior chain problem, meaning the glutes aren't their primary mover, they're relying on adductor magnus as a hip extensor. That muscle can be extremely tight and supporting that fascial line to restrict rotation. And you'll probably find that asymmetry in the muscle movements. When it comes to the torso of the anterior chain, we're looking at the abdominals, but we're not really talking about the rectus abdominal, more so the internal external obliques, this being the transverse oblique, which is really a primary rotational pattern. But the internal external obliques that are cross patterns, that fascia connecting right to the ribs where the pec attaches. So those have a big influence, obviously, and our ability to stabilize and center our mass through that line of that plane of motion, that axis of motion, also has a influence on our internal external rotation components. Then I'll just take a look at the posterior fascial line, or you can just think of it as the connection of all the musculature. Biceps femoris we talked about, the glute, and as we come up this chain, it would be the glute, maybe some posterior, the biceps femoris, some posterior adductor magnus on the left leg, and the the contralateral, the opposite glute muscle, lat, lower trap, all of this kind of connects. So you've got same side glutes, same side hamstring and adductor, and then opposing latissimus and traps. And again, the latissimus is its origin is off of the lumbar sacral fascia, and that lumbar sacral fascia the glute attaches to. So that posterior chain has a big component to rotation. In fact, it's something to really pay attention to. You're going to see an imbalance somewhere in these posterior chains. And this is why I always talk about the connections that the torso has with the pelvis, and how each assessment is assessing all of those as a component, not just one thing. So just gives you an insight to kind of the posterior chain to start thinking about in the connection of corrective exercise or approaches. Posterior chain activation muscles. Again, you've got erectors on both sides of the spine, and erectors, when they're active, they're pulling us into extension. But if we have an asymmetry somewhere, whether it's because of the ankle, because of the hip socket, or the thoracic back, or the habitual patterns of habits of patterns that we create in our life, a baseball player who throws the same way all the time, a golfer, whatever it may be, you're going to see a difference in musculature girth here. And as one erector spinae, and I'm calling all three of them erector spinae, but as one group of erectors works, it becomes stronger, thicker, and tighter, which is going to cause rotation of the torso. So again, from the toe touching pattern, if you see a difference in muscular girth of those erectors, you're going to almost suspect that you're going to see that come out in your standing rotation pattern too, because the body is used to rotating one way, not the other. And I just don't ever want you guys to get away from how big of an influence the lat has on all of this, because it is part of that lumbar sacral fascia. The gluteus maximus is part of that fascial line as well, and they all influence it. So the lat is a big, flat, broad muscle that can have a lot of contribution to the movement of the lumbar sacral pelvis, especially if someone's extremely tight, which again we were looking at in the standing backward bend pattern. Just raising the arm and the flexion gives you an indication of how much tightness is in that lat muscle. And then obviously the lower extremity posterior chain, you can see the size of that biceps femoris on the lateral side of this right leg, the glute contribution, and then the cross pattern. These are the deep 6 external rotators of the pelvis, being the piriformis, this big guy right here. They all have a strong influence on that external rotation. So be thinking of that. And you can see this very long, flat line here. This is all adductor magnus attachment. You can see there's more of a posterior attachment to that right on the ischial tuberosity. So that posterior chain of posterior portion of the adductor magnus can have big influence on the movement of the hip socket. Here's a lateral view of it on the right here. On the left, the adductor magnus contribution on that posterior hip. Pretty impressive stuff. I've included this diagram again with all of the muscle activations and actions, and then obviously the ones in bold or the color are the prime movers. So just kind of keep this in mind as you're looking at internal rotation. If you've got limitations in one, that means you've probably got overactivation of the other group. And it's not a matter of just stretching that tight muscle group. It's really a matter of activating the weaker groups that that contralateral group, or the antagonist group that is probably weak and inactive. So hopefully this helps you guys out. Just another diagram to illustrate how the musculature is arranged and their actions and influences. And then that just leads us into the corrective exercise approach for standing rotation. Again, my focus isn't on just cranking on a hip socket to get it moving. It's understanding why that hip socket got locked. And we have to take into account ankle mobility, have to take into account their ability to go into flexion or extension, which again is synonymous with internal external rotation. So I'm going to go through a very similar pattern that was present in the corrective exercises of the toe touch and backward bend, which is just encouraging symmetry on the right and left hip. The cat and dog is one of the best exercises to establish symmetry, not just the hip flexion extension position, but also thoracic and spinal, because you're not able to rotate when you're in this position. And learning this pattern is very important for most people, especially when you have them try it and they're lost in it. And the minute you have someone go into a cat and dog position doing the exercise, you'll know how kinesthetic their body is and how adapted it is to moving in this movement. If they've lost that, it tells you a lot about their inability to move effectively or authentically through the patterns that we're looking for. And then I said, so I'll take someone onto the ground and take away any influence, the thoracic spine or any, because if we find an asymmetry, just understand this, if you find an asymmetry in ankle mobility, if you find an asymmetry in standing rotation, then you can assume that you've got compensation for that somewhere. And that compensation is going to breed itself up into the lumbar or thoracic area, even the spine, the neck, shoulders, etc. By laying someone on the floor flat, gravity's holding them down, they're not able to rotate, they're not able to compensate for that lack of movement in the pelvis, and it's a great place to start. So cats and dogs, and then I go into the active frog, which is encouraging external rotation. If you find someone that's really restricted in internal rotation, then take their feet out wider, have them do a wider stance and try to really force internal rotation there. But I'll start usually with the feet together, and emphasizing external rotation. And it's not just trying to take someone through a range of motion. We're actually trying to activate the musculature. We're doing some adductor stretching here. Obviously, if we go out into that position with the frog, I'll actually have people engage their glutes when they go externally rotated. But when they come internal, I'll actually have them spread their feet and internally rotate and activate those internal rotators, which they're going to feel in the inner thighs, which is your adductor muscles, right? So it's a great exercise to create symmetry of that movement pattern. And I'll have them take a break and stop and go back into it. If I see, it's usually like the warm up of that hip internal external rotation pattern I want to get them through. And then I'll take them into a crossover, which is again addressing that rotational imbalance, right or left. And you'll see it come out here. When someone goes one way, their hip crossover will look really good. When they go the opposite way, they'll have some difficulty. They'll feel it in different places of their spine. They'll feel in different places of their hip. And sometimes I'll have them alternate through this. I'll have them go through active frogs and hip crossover, back to active frogs, back to the hip crossover. I may even do it 3 times just to start getting symmetry established and understanding what the body's doing. One important piece of this hip crossover exercise is not just that quote-unquote pure form stretch where we try to pull the leg up, stretching something. This exercise, when your foot hits the ground, in this particular picture, the right leg's up in the air, so when she rotates to the floor and her right foot's touching the floor, I'm actually having her externally rotate that femur, pressing it out, activating the glutes. And it's not just gluteal engagement. If you were to feel someone's musculature of their spine, especially in the lumbar area, as they press their knee out, the contralateral, the opposite side erector will engage. And again, that's that fascial line, that's that connection of the contralateral pieces from the lower extremity to the upper extremity. It's a really neat exercise, especially if someone has a big muscle imbalance of the thoracic area due to rotational patterns. It's a great exercise for thoracic mobility as well. And then I'll have them go into some flexion extension exercises. We've tried to encourage some internal and external rotation. Now we'll get the hip to start understanding what that means for hip flexion and hip extension. So I like using the active straight leg raise. I'll actually have people do I might even have them do active bridges here. In fact, I'll actually add that picture in for you guys. I like having people do active bridges from time to time, just because we're encouraging that hip extension, hip external rotation component. If they are restricted in external rotation, I'll definitely have them go through hip flexion patterns. If it's an internal rotation pattern, I spend more time on that hip flexion, hip internal rotation pattern. But if I find, because this exercise, you're encouraging both. We're reinforcing it through the movements that we created to get hip movement. Now we're going after getting the hip to understand what to do. If it's a tight internal rotators, like strong adductors or something like that, then I'll actually have them do some active bridges just with a strap to take away the adductor influence, getting glute to fire and going after it that way. So I might throw that in there as a corrective exercise. I'll get them loaded then. Their body's understanding how to move. Now we're going to teach the rest of the body what to do with that movement. Standing wall twist is a great exercise to encourage internal and external rotation of that hip socket in both directions with the influence of what the spine is supposed to start learning to do. In this position is a really challenging one, especially if someone is restricted one way. You'll see that restriction in their thoracic back as well as their hips. Great exercise. I go to the hip hinge pattern now because we're just teaching flexion extension. By spreading that foot apart, we're encouraging more internal and external rotation of that hip socket. So it's reinforcing what we've been trying to build the building blocks on. And then I'll usually end with a pattern, hip extension, gluteal activation pattern, just to reinforce that new hip socket positioning. Sometimes I might just leave them with the hip stance, the hip hinge stance, but I like to leave them with something of activation of the glutes posterior chain. Most people are weak in those glutes and they'll benefit from it. So again, the standing rotation pattern is a valuable tool to use in your assessment of dysfunction. It's in a position that you've already gathered a lot of information just from the first 3 assessments. So the standing rotation kind of helps validate some of the stuff, and it starts setting you up for the next 2 patterns that we're going to cover later, sitting rotation and single leg stance, to almost predict what you're going to find in those and lead you in that right position. So that's really all I have. I thank you for being on the call, and it's great information. So learn your patterns. Thanks.